I would like to finish on one thing with Amit here. Riyadh brought up a very important point, and endpoints. No doubt that we all kind of, are probably more geared and more used to overall survival for anything, because ultimately the ultimate reference is people are alive and doing well. But of course, there's the in-between of many other things. And I think just to simplify the question and make sure that we put it in context, why would you see that there's certain arguments for example, pushing for PFS, for example, in clinical trials in HCC?
Yeah, Ghassan, before I get to that point, I just want to say one other thing is, I think that you're finding that we have more and more tools that we're comparing, right? So you already had all of the embolization therapies. We talked about bland embolization, chemoembolization, radioembolization, and now you also have SBRT as a local therapy. And I think this is a theme that you're going to hear throughout this discussion today. But I think that we have to be more nuanced in terms of how we discuss these things, particularly as we start to say these have relatively the same in terms of overall survival. And I think what we need to start really pushing the field forward is looking at either radiologic markers of response or biomarkers, so we can actually start making smarter decisions. And so we don't just end up depending on local expertise, but really trying to make the right decision for the individual patient in front of us. I know that we're not there right now, but I really think that's where we have to push the field to go in the future. Now to get back to your question in terms of these intermediate outcomes and why these are important. And I think that really, Riyadh talked a little bit about this, particularly for local therapies when you're talking about BCLC A and B, and it can be tough to compare therapies when you have the post-progression therapies that can confound any kind of interpretation of these comparative studies. And so when you take a look at this, you can use some of these more intermediate outcomes, like time to progression, or if you're looking at the radiation literature, these local controls as a way to compare these therapies in terms of their actual efficacy for what they're trying to achieve.
Yeah, I have to say, this is a little bit debatable. If anything, as Riyadh said, there's quite a bit of interest in regard to what do those other endpoints mean. And I think the latest introduction, as we heard, is the TTUP. Maybe Riyadh, just to make sure everybody understands TTUP again one more time, tell us a little bit more about it, because I think it's a little bit, which I have to say, came right from the left field and rather intriguing.
So TTUP means time to untreatable progression. In other words,
untreatable progression.
Time to untreatable
I need time
progression.
to even understand that.
Yes, so let me take some time to try to explain as best I can. So the idea here is that when you're performing an embolotherapy, there has to be a right balance as to how many embolotherapies you implement to maximize response, OS, purported OS, and permit the patient to be well enough to be treated early enough with systemic therapy. That's where the balance is. And so the concept of TTUP comes in saying, hey, I want to make sure that I treat, but I don't have a patient decompensating to Child-Pugh B or Child-Pugh C. I don't want to embolize until, for example, I've occluded all of the vessels. And so this is what this means. It means that you don't want to be in a situation where you want to do a local regional therapy like embolization and the vessels are thrombosed or the patient is now Child-Pugh C. So TTUP is the idea here. Let me try to maximize the benefit for the patient, and when they're still well enough, let's initiate systemic therapy. That's the concept. It's intriguing. It's interesting. Unfortunately, one of the issues that arises is the variability in child score, number one, and the variability in some of these definitions that people have used. And frankly, TTUP, by my review, has been defined 3 or 4 different ways already. So I think leaders and scientists have to get together to figure out if we're going to use that, what is that definition, and then we can all follow that same sort of pattern, and then we can proceed.
Peter, do you have any favored endpoint, or you think is the right one to use in regard to those studies?
It's very nicely pointed out by Riyadh that this is a very individual and in the end ill-defined sort of situation. However, this is clinical reality, and we know that progress is, if you have it in a sharply defined situation, something where you stop a clinical trial because the endpoint was reached, but you might still continue with the same drug. And we have been doing that. We have seen patients reaching the clinical endpoint of progression, and we kept the patient after the trial on drug for 2 years because we saw what was not captured, a drop in alpha-fetoprotein, and the patient was doing fine. So progression is very complex in hepatocellular carcinoma, and several trials have tried to capture that that they allowed clinical relevant progression, something like that, so that you can continue because you consider that although it's objectively speaking radiographic progression, nothing which would prevent you from continuing. Coming to endpoints, we had that discussion, and it's driven by oncologists that we need something, particularly in a situation where we go from first line to second line to third line. There's so much along those lines which is impacting, and then you need to have something in addition to overall survival. PFS is probably what most people then consider to be relevant, but I mean, the trials which are around tell us that those surrogate markers are not always translating into the real endpoint overall survival. Honestly, I'm stuck. I'm a bit confused here what to recommend. It's the number one question you are asked in any discussion with Big Pharma. What endpoint would you recommend? To come back to the initial discussion, it's very relevant to keep patients on drug, although they might have progressed, and that requires dose reduction, that requires a break, and that requires time and second assessment. How to bring that in a clinical trial? Good question.
If I just wanted to add one other thing, Ghassan, if I may, about endpoints. For me, this is one of the most important issues that we need, that leaders need to address in the field, is to define endpoints that are going to be practical, where the field can continue to move forward. It's long been my contention as an interventional radiologist working mostly with BCLC A and B patients where the survival is very long, that I'm sort of stuck, as Peter was saying, I'm sort of paralyzed because I'm statistically paralyzed because I can't do 5,000 patient trials. And the BCLC-C field is so dynamic with 5 and 6 and 7 trials that my post-progression argument that I used 10 years ago with sorafenib now is complicated by 5 other post-progressions. And so it's impossible to perform an OS study in those fields. You're right, it's the objective endpoint, it's the best one if we can, but we're statistically stuck. So I do think, to be fair, and I think for us to have sort of an honest discussion about it, we need to find those endpoints that are relevant, that people will act on, that are relevant for patients to move the field forward. There's a reason why there's only 2 TACE studies from 20 years ago that we still quote, right? Because they were controlled to no treatment and nothing else has happened. Those were in small, single centers, 40 patients, and nothing's happened since then. There's a reason. It's the statistics and it's the need for this OS endpoint.